Hello, everyone. My name is Jacklynn Crump. I am a nurse practitioner and a DNP student at Maryville University. And this is a PowerPoint presentation to go over my DNP project titled Impact of X-WAIVER Exemption on Opioid Use Disorder Treatment Access. This is to review the committee members who are wonderful. My chair is Dr. Buck. The second reader is my 707 instructor, Dr. Stewart, my community members, medical director, Dr. Emily Harvey, and this director of psychiatric services, Brian Hagan, who's also a DNP. The background for my project has to do with the unbelievable critical public health crisis that we've been dealing with for a very long time now. The opioid epidemic, it just remains critically problematic, economically burdensome. It's been worse year after year. And as of my data, I'm sure the numbers have increased, but from 1992 to 2022, there had been over 725,000 reported deaths from overdoses, and specifically with opioids. My project, the basis of my project is to look at buprenorphine, which is a proven medication that significantly reduces overdose risk. It improves recovery efforts. Like, it supports recovery efforts. It's an amazing medication that really helps impact communities who are affected the most. And this all starts with the Drug Addiction Treatment Act of 2000. So this was really, really meant to be a wonderful thing and a good starting point for providers to really impact individuals with opioid use. It established what's called an X-WAIVER. It's an additional DEA. It was an additional DEA requirement. You had to do additional training for prescribers, all prescribers, MDs, PAs, nurse practitioners, DOs, everybody, and you could do the additional training and get the X-WAIVER so that you could go out in the community and treat opioid use disorder with medications like buprenorphine. And it really was meant to impact the medical community in a positive way. But I think just the evolution of the opioid epidemic and the different waves and all of the deaths, finally the Department of Human and Health Services decided that the X-WAIVER was not helping with the expansion of treatment. And so as of January of 2021, they decided to do away with the X-WAIVER requirement. They did a complete removal, and the goal behind that was to expand access to care and to allow all providers, whether it's primary care, an emergency room provider, really focusing on harm reduction, meeting patients where they are. If somebody was in front of you and they were ready, you could initiate medications like buprenorphine and start the treatment process for their opioid use disorder. However, the evidence shows that policy reform alone, so this X-WAIVER removal alone, may not lead to increased prescribing. The big thing that I've learned, there's a lot of organizational barriers and provider barriers and program manager barriers, and a lot that impacted on a community level, impacted this big federal reform. And my project also, I wanted to understand the real world impact of policy reform as it pertains to reducing, mortality with this epidemic that's been going on for years. And my project, at a community level, my project was assessing whether or not the Department of Health and Human Services, the X-WAIVER exemption, was going to impact our buprenorphine prescribing practices within Best Care Treatment Services. It's a community behavioral health center in Central Oregon. As I'm sure everybody has a significant amount of literature, I've included the full reference list at the end, but this is what stood out the most as far as what drove my project and the design and what I was looking for. So first off, regulatory barriers, including the X-WAIVER, have historically limited buprenorphine prescribing. Buprenorphine reduces overdose risk and supports long-term recovery in individuals with opioid use disorder. The removal of the X-WAIVER in 2021 aimed to increase prescribing capacity. Studies show that policy changes alone do not significantly increase prescribing rates. Organizational support is also needed. And that was as of 2022, 2023. And that was a year after the exemption. On to the next. States that eliminated the X-WAIVER reported higher prescribing rates and treatment engagement. That was as of 2025, so that's a good sign. Clinical guidelines endorse expanding access to buprenorphine as essential for effective opioid use disorder management. Organizational and provider barriers, such as workflow issues and cultural attitudes, persist despite regulatory changes. And lastly, implementing structured provider education and team-based approaches can facilitate practice change. So those are the important, very, very quick summaries of some of the literature I used in this project. The theoretical framework that guided my project was Lippitt's model for change. I think that it fit the best as far as grounding my project. Its proven approach to change management. I just think it was very appropriate. So the overview, it's a systematic approach to assess, plan, implement, and evaluate organizational change, which is exactly what I was aiming to do, to see if we had organizational change based on this really big reform. The application, it facilitated stakeholder engagement and buy-in, developed educational models and interventions, and ensured sustainability of practice changes. And the impact on work, it really provided a roadmap for staff education and workflow improvements, which really plays a big role. I'll talk about that at the conclusion. And identified barriers and tailored strategies. So it kind of fit my project like a glove. My design, it was a retrospective audit. So retrospective observational study that I looked at de-identified health record aggregate, just numbers. There was really nothing else to it. We pulled the number of buprenorphine prescriptions and patient visit counts from Epic and Dr. Cloud, those are our two softwares that we were using through this. And then we looked at a prescription to visit ratio. The time frame, so I did 2 6-month periods. The first 6-month period is the 6 months right before the change occurred, and then I did the 6 months just post change, and those were pre and post. I used a z-test, which kind of makes sense for this, and the rationale, it allowed an evaluation of real world prescribing patterns over time, and it enabled the pre and post policy data that I collected, because I had a lot, and it gave us really great answers on how statistically impactful what we collected actually was. So it was a good choice. The participants were adults 18 and over that were enrolled in medication-assisted treatment services at Best Care, and they had to carry a diagnosis of opioid use disorder. So I will go into specific numbers during the results section, but I sampled prescription data, pre-X-WAIVER 6 months and post-X-WAIVER 6 months. And then I collected the patient visits, both pre-X-WAIVER and post-X-WAIVER, in the same 6-month time frame. And my sample sizes were very large. So that was very unexpected. When I was working with the statistician, we were really nervous that I had no idea when I was putting this together. We thought, well, maybe I'll be really lucky if I get 100 or 200 prescriptions, and that's really what I needed to show a statistical significance. And then I ended up with thousands of prescriptions and thousands of patient visits for the pre and the post. And as far as demographics, I didn't have any demographic details. It was all aggregate data. It was all de-identified. There was nothing included about any patient. It was just basic numbers. And as far as characteristics, the main focus was organizational prescribing patterns over the 2 time periods that I talked about. Okay, and again, I know I already said this, but I used the z-test for the difference between 2 proportions. And the reason why, that's the most appropriate test for proportions. And I was looking at prescribing rates before and after the policy change and assessing whether or not there was a statistically significant difference in the prescribing rate to the patient visit. And this is just the test that was suitable for my large sample sizes because I had no idea. And the outcome measured, we were doing prescription to visit ratios and changes in prescribing behaviors over time, and the significance level was set at 0.05. And here it is. This is where we'll go over everything. So I think in general, obviously the pie charts are a really great visual of what I'm saying. So overall, there was a slight increase in the actual number of prescriptions. So the pre-X-WAIVER removal 6-month time frame generated 2,236 prescriptions for buprenorphine. The 6 months post-X-WAIVER exemption generated 2,362 prescriptions. The big change is this. So the patient visits significantly increased. Same time frame, 6 months prior to the X-WAIVER exemption, there were 3,276 patient visits. The same exact time frame for the 6 months post X-WAIVER exemption, the rates for patient visits rose to 4,794 visits. And so if you look at the top pie chart, the red is showing how many buprenorphine prescriptions, like how many visits generated prescriptions, versus the green is a patient visit with no prescription. And if you look at the bottom, it's decreased to like less, just under like 50%. And so the prescription to visit ratio decreased significantly from 0.68 to 0.49 with the p-value listed. And this is showing that despite more patient visits, prescribers issued fewer prescriptions per visit after the policy change. And my z-test confirmed that the decline was statistically significant. And the implication for all of this is that simply removing the X-WAIVER alone did not impact our community behavioral health center. We did not have an increase in prescribing rates. And the organizational barriers that created that scenario persisted despite the federal goal at increasing access to care. As we all had limitations, my limitations were sample size and scope. So it was a single organization, and I did a kind of a short 6-month pre, 6-month post, so I didn't capture long-term changes. And a retrospective design relies on existing data, which may lack contextual details and control over variables. Educational intervention. So this one was big. this all happened in 2001, and I came in like 2003 or 2004 and said, I'm a DNP student and this is my project and this is what I want to do. So all of those changes had already taken place. I didn't come in and say, this change is coming and I need to educate everybody and do formal staff training to, help implement these changes to increase prescribing. I just looked at the past and said, hey, this is what the government wants. Did we do that? Did we succeed as an organization during this specific time frame? And so that's what I looked at. So I didn't have any formal structured staff training that was implemented during the study. And my unmeasured factors, I did not account for external influences such as regional policies, staffing changes, or provider attitudes. And the data limitations, it's all de-identified. I didn't have any demographic or clinical details. So the discussion, it's really important. The interpretation of my findings, we had an increase in patient visits. So could we spin it that we had greater engagement? Yes, but I don't think that that equates into an improvement in access to care. MAT and buprenorphine and these medications are crucial in the treatment of substance use. And so we had an increase in patient visits, but that did not correlate to an increase in prescribing. And so the X-WAIVER exemption did not lead to more frequent prescribing. The implications for practice, I keep saying it, regulatory change is insufficient on its own. You have to go against and help with the evolution of organizational and provider barriers. And there needs to be an emphasis on targeted staff education and cultural shifts. I say that because when I went back and I looked, there was really no staff education. There were informal emails that were sent out where, everybody was like, oh, hey, this is a really great thing and it's gonna change our community and everybody's gonna be able to prescribe, and that was kind of it. But there was really no like targeted education and helping providers understand it, and like how would you do this? How would you help somebody in the midst of all of this? And so the overall answer to my research question is the removal did not significantly increase buprenorphine prescribing at Best Care. And again, organizational factors continue to influence prescribing behaviors despite policy reform. And the overall conclusion, policy reforms should be complemented with organizational strategies to effectively expand access to MAT. It's just not enough. It's got to be every level, starting from the provider, working all the way up. So implications. For providers, this project highlights the need for ongoing education and support to translate policy changes into clinical practice, and it encourages the development of strategies to address organizational barriers to prescribing. For patients, it suggests that simply removing regulatory hurdles may not immediately improve access. There needs to be organizational process evolution. That's just what it is. Everything has to evolve. And it also emphasizes the importance of integrated care approaches to ensure timely treatment. For the healthcare community, the project reinforces that multifaceted interventions are necessary to expand access to MAT, to medication-assisted treatment, and it supports advocacy for combined policy and organizational reforms to reduce opioid-related mortality. The overall impact, we have to do more from providers, from med techs, from therapists, from like Best Care as a whole, to our HR department, to our education. We just have to do more to get medication-assisted treatment to individuals with opioid use disorder. The conclusions. My project assessed the impact of removing the X-WAIVER. There was an increase in patient visits, but no rise in prescribing rates, and this highlights ongoing organizational barriers. My project shows that policy change alone is insufficient, and we need organizational strategies to improve access to MAT. And future efforts will focus on targeted interventions and long-term evaluation. And overall, this DNP project has strengthened my leadership, my assessment, and my change management skills, fueling ongoing advocacy for healthcare improvements. It's been very challenging, but a blast. This is my extensive reference page. You can also use the QR code and it'll bring up a beautiful PDF that's in APA format for you to review. This project, again, I cried a lot. There were a lot of late nights writing papers and reviewing spreadsheets of data, but it was very, very well worth it, and I have enjoyed the journey. Thank you all for watching.